Dr. Lily is having some challenges with her audio. I think she's not able to hear what I say. Uh, Lily, can you hear me? Lily, can you hear? Can you hear me speak? I'm sorry, Lily. This is not working. Uh, Lily, the problem is with your audio. Maybe you could consider taking that off. Okay, I'm not going to, spend any more time on that. I hopefully Dr. Lily will be able to figure out her challenges. One last time, I'm going to just try calling her. So, welcome to this event on women and cardiovascular disease. So what do I mean by cardiovascular disease? So, cardiovascular disease is diseases of the heart. So, heart disease can be, coronary artery disease, which is what you hear of about most of the time, which is when people have a heart attack. Now, women have heart attacks too, which a lot of people don't know that. Then women may have heart failure, it may be heart rhythm problems. Those are all considered to be heart disease. Then there is stroke. So stroke is when blood supply to a part of the brain is compromised, and you have a part of the brain that gets destroyed. So heart disease and stroke are together called cardiovascular disease, or CVD, in our world. And here I am too. I was an obstetrician gynecologist before, and like Dr. Lily, she was also an obstetrician gynecologist, and she was an endoscopic surgeon as well. So both of us, took care of women through the reproductive years. But over the last few years, we have come to know about so many things in relation to reproductive history in women, which we didn't know back then when both of us were practicing obstetricians. So basically, women and cardiovascular disease is somewhat different from men in many aspects. And this is obvious. Like, for example, women and men are not alike, right? From, the genes. So women have XX genes, whereas men have an X and a Y gene. So every cell in your body is different, in the sense that women have XX and men will have XY. So that difference goes quite deep down, and it's not simple things like. So there is a difference between sex and gender. So sex is biological, and gender is cultural. It's cultural and social construct. So Lily, can you hear me now? Hello, Lily, can you hear me now? I am sorry about these glitches. I think I'm going to try calling her on the phone. Lily, I have sent a message.
Able to hear me? Are you able to hear anything, Shabnam?
Yes, I can hear you. I think you can't hear me. So I suggested you introduce yourself.
Okay, good. So, apologies for this delay and for the technological errors, which I don't know how to manage. But I'm so thrilled today to have you, Dr. Shabnam. Shabnam Kaskar is a very, very old friend and a very dear friend, esteemed gynecologist. I've had the privilege of working with her for so many years in Mumbai. And now I'm so thrilled that you're a board certified FMNM practitioner, and you're also faculty in American College, and you lecture worldwide. It's a real privilege to have you here today, Dr. Shabnam, and a rare opportunity for us to hear from you. Thank you very much for being here. And would you
Thank
like to
you
say
so
something
much.
more so that young doctors can feel in, inspired to take the next step from a very regular modern medicine background to move into something that's new and exciting and much more worthwhile? At least I think it's much more worthwhile.
So, Lily, will you just describe what you're doing now, versus what you were doing several years ago? What made you move into integrative medicine versus, traditional OBGY? You are an endoscopic surgeon.
My
Okay.
audio is
Lily, I'm sorry. There is some problem. Maybe you could consider taking out your phones. So I'm not going to spend any more time. So why are Lily and I dressed in red? So I'm proud to wear my, Go Red for Canada the badge, the lapel pin. So in the US and in Canada, there is a lot of awareness building about women and cardiovascular disease. Now, I hope one day it happens in India as well. I've been trying to talk to a lot of people, and it would be lovely if anyone in the audience is, listening in. If you want to reach out to me and organize an event, so I've been saying, no, we should have all ladies joining in dressed in red, and we are going to celebrate, all this and also build awareness along with that, because just talking about health can be sometimes awfully boring. So mm, that is why I'm in red. I also have a red cup, and I'm very proud to wear the Canadian lapel pin this time because I have one. So in the US, they have a red dress. So it's a red dress campaign and a pin, which is like a red dress. So going back to women and cardiovascular disease. So what are some of the risk factors? Because what Dr. Lily and I want you to go away with is things that you can do for yourself. It's one thing is to know your risk, and the next thing is to understand and take steps for yourself. Yes, your doctor is there to help you, but both of us are very interested in sharing things that you can do for yourself right away. Like, you don't have to necessarily wait for a doctor to tell you, because these are things that are lifestyle related. They are things related to your food, to, to movement, to sleep, to things like that, which you control. Your doctor doesn't control all of that at all. So what are the different risk factors? Now, I have on my website, there is a questionnaire, and I will try to see if I can do a closed captioning. Oh, okay. I am typing the name of the website. So mm, this is my website, www.carmd.com/heart, and you will receive a link to that particular website. So that has a list of all the risk factors in women that we want you to be aware about. So traditionally, what have been the five top risk factors for cardiovascular disease? One is smoking, then obesity, cholesterol abnormalities, having hypertension, and to that has also been added a continuous sitting. However, not all of you will have all the risk factors. But besides the top five risk factors, there are a lot of other risk factors which we were not always very familiar with. Now, because it's two former OBGYs talking here, we want to, and when I first got to know of all that, I was really surprised. Like I said, oh my, there is so much I didn't know. So our entire, an obstetric or gynec practice, so all the reproductive history, what are the major things in factors in your reproduction which place you at a higher risk for cardiovascular disease? Things like having pregnancy diabetes. Now that in amongst South Asians is extremely common. Pregnancy diabetes is one, pregnancy hypertension is another one. Then having any kind of miscarriage or stillbirth, delivering a baby which is smaller than smaller than the expected gestational age. Then miscarriage is another one. Then of course PCOS, though not directly reproductive history, that is extremely important. So all these factors raise your risk for cardiovascular disease later on in life. And interestingly, with diabetes, even if you do not develop diabetes later on, like you had pregnancy diabetes, then you delivered, you recovered, your blood sugars are back to normal, even then you are at a higher risk. Now, why that happens? Of course, we know that there's something called insulin resistance, which is the underlying problem with many of these conditions. So, Lily, can you hear me now? Would you like
yes,
to?
I can. Not
Okay.
very well, but I
So
can.
So Lily, do you realize that all the reproductive history that I talked about, this was like our daily everyday practice in when we were OBGYs, right? And back then, did you know that many of this condition would place women at a higher risk for all these things? Hello, hello, Lily. I'm sorry, can't hear you
Sorry,
at
not
all.
so well enough to answer you. Please carry on.
Sorry about that. So. mm, Maybe what I'm going to do is I'll type in the chat so that you can just chime in. So the website which has a list of all the risk factors, it's like for our even our day-to-day practice, I need that because the list is so long. So number one, you can go and check all the risk factors for yourself. But more importantly, some of the things we wanted to highlight today, because some of the things are very relevant for people in India, and some are relevant for, of course, everyone. So one of my pet projects, if you want to say now, is to build awareness about hypertension now. So having high blood pressure. So how many of you know your blood pressure today? If not today, maybe in the last week, did you check your blood pressure? If you didn't, it's probably a good idea to do that. It's not probably, it is a good idea to do that. So Lily, I'll just let you chime in with a few words. Uh, Please, will you just add some of the things that you think are most important women should know about? So I'll let you speak now, Lily. Lily, please, will you say something about your view of women and cardiovascular disease?
I don't think so. I can
Hello.
barely just manage to hear.
Oh, okay. Sorry. Then I'm sorry about Dr. Lily's challenges in the with the technology. So I'm just taking over. So basically, what we wanted to talk about is all the different number
But I
one.
really do want to know from you, Shabnam, what can we do to understand the differences between heart disease in women and in men? So,
Okay,
why are they not the same?
okay. So basically, now I don't know whether all of you could hear what Dr. Lily said. So she asked that why is it that men and women are different when it comes to heart disease and stroke? So, and I talked about that at the beginning, actually. I think Dr. Lily couldn't hear at that time. We men and women are completely different from a biological perspective in the sense of the X and the Y chromosome. So obviously, as you know, a lot of nowadays there's a lot more awareness building happening. So women are not small men. So women, number one, yes, when it comes to heart disease and heart attacks, chest pain is the commonest presenting feature. 70% women have chest pain, but unfortunately, there are some other symptoms that women may have, which they don't realize are related to the heart disease. So some of the things women have experienced, and some of these symptoms have happened like before they actually had the chest pain and the heart attack and everything, and they rushed to the hospital. So one was fatigue, another one was jaw pain, then fatigue was like profound fatigue, and they never thought that that was because they were having a heart attack. Then symptoms of reflux, so that is basically gassy feeling or pain in the upper abdomen. So those are the things which, and some of them have even been actually dismissed from emergency rooms saying it's just a digestion problem, you're just having GERD, and they went home and then they had to come back because they had a full blown heart attack. So chest pain is not to be ignored, and particularly, and recently I was actually on a conference in Canada. This was a virtual conference, a Women on Cardiovascular Disease conference. And one wonderful thing they had was they had actually women who have lived through an experience of a heart event talk about their experiences, about what they felt and shared and how they went through the journey. And many of these women were like very young. They were less than 45, 50 years of age. Because a lot of the time, people don't think that women of that younger age can have a heart problem. And of course, some of these problems, I've been asking, my colleagues in India if any of them have been facing. So there is something called SCAD, SCAD, that is spontaneous coronary artery dissection. So SCAD is, again, the presentation is with sudden severe, chest pain. And quite often it is in women who have just recently delivered, and they are young women. So very often what happens, young women, feel chest pain, but they are not thinking of, I'm having a heart attack. That's not the first thought that comes, because you don't fit the usual picture. Because what is the usual Hollywood picture of a man having a heart attack? It's like they have a heart attack and they fall and they keel over, and all. Women don't always have that. So one of the pioneers in women and cardiovascular disease, Dr. Noel Mers, she is in Los Angeles at the Cedars Sinai. So she describes it very, in fact, her TED talk was what got me interested in this whole journey. So she says, men explode and women erode. So again, sorry, a little technical. So explode meaning, so how does someone have a heart attack? So this is a plaque so this is the heart vessel. There is a plaque. A plaque is a collection of a lot of different materials along with cholesterol and inflammatory chemicals and everything. So when that one bursts, it causes obstruction of the artery. And so that is a plaque rupture. Now, with women, what happens, it's not always such a dramatic event. It's like slowly the plaque erodes. Then women may also have what is called non-obstructive coronary artery disease. So women don't have, lot of women don't have the severe obstruction in the arteries supplying the heart, but at the same time they have other problems. So then these are like, I don't want to go into the technical stuff, but the thing is, it's microvascular disease and all those things. Then women have another kind of something called takotsubo cardiomyopathy, which is sudden reactions, like even a happy thing. That was surprising to me when I find out that if you have a surprise birthday party and you have your friends suddenly opening the door and there they are, even that can cause a takotsubo. So takotsubo is basically an octopus trap in Japanese. So it looks like that. So the heart shape becomes abnormal, and it's basically a stunning of the heart muscle. But the good news is that most people recover from that. So that is the good thing. So those are some of the ways they're different. Then the other big area, Lily, is, all the medications. So until about 2016, women, when even if they were included in clinical studies and research studies, they were not, studied separately. Like it was sort of assumed that if this particular drug worked in men, it should work the same way in women. Now we are finding out that that's not quite so, and we still need a lot of research. Of course, we need a lot of research from Indian, South Asian women as well, South Asian men as well as women. But so there is a research gap, no doubt. And again, a lot of it is, so what can we do in the absence of a lot of research evidence? Well, one thing is, your doctor does, can help you. For example, when it comes to antihypertensive medication, so blood pressure medicines. So one of the ways that blood pressure is managed is routinely, you regularly check your blood pressure. So if you are on a certain medication and your blood pressure is not under control, what are some of the things you can do? So Dr. Lily and I will discuss a little bit about that. Next is, you need to go and meet your doctor. Your doctor can help you, maybe add another medicine. Again, track your blood pressure for 2 weeks, 1 month, and see where you're going. Is your blood pressure coming down or it is not? But you need to take the onus to follow up. So the problem with hypertension is very often there is no symptom, and if you don't measure, you don't know. So we'll come to hypertension. Another thing that Dr. Lily and I feel very strongly about is, again, I have digressed into what is relevant for women, because having a hysterectomy, so having a removal of the uterus, even if the ovaries are retained. So this was actually, Lily, back in the days, we used to think, if the ovaries are there, then women should not be getting into menopause early, right? And we were so wrong. So studies have found out that if women have had a hysterectomy, that means removal of the uterus. And I'm talking about non-cancerous conditions. Cancer is a different story altogether. So non-cancerous conditions, they've had a removal of the uterus. And even if the ovaries are retained, those women will get into menopause much earlier, number one. And the other thing is the menopause is very sudden, because suddenly, the uterus is not there. Now, why does that happen? Though we don't know exactly everything, but we do know that one of the things that happens is the uterus is one of the target organs of the hormones like estrogen, progesterone. So if the target organ is not there, then the ovaries, they don't produce as much hormones, number one. Number two is, in the process of the surgery, the blood supply to the ovaries can get compromised. So if the blood supply to the organ that is making these hormones is compromised, the levels of hormones may not be what they were. So what happens is, most studies have shown that women get into menopause within, sometimes it is, again, it varies across, all women. It may be as soon as 3 years. Now, Lily, what was shocking to me when I was going through some of the literature recently, that the age of having a hysterectomy in India is shockingly early. So again, India being such a diverse country, it's not the same all over the country. This was like, so it was less than 40 years of age. And most of these women had a hysterectomy because they had excessive bleeding. So this was not cancer. This is non-cancerous conditions having a hysterectomy before the age of 40. Some of them were as young as 37. Like, then apparently some new government insurance project, this was one of the scams apparently, where women started, a lot of women had hysterectomies because of that insurance. Now that is so wrong at so many different levels. Anyway, those are not things that,
Maybe because in India, women finish childbearing quite early, so they
yeah.
think that it is now a redundant organ.
Hmm. So back in the days, and I'm talking about a long time ago, and I know there are some gynecologists in the audience today, what were we taught? We were taught that, okay, a woman has excessive bleeding, she's completed her family, she doesn't want any more children. And if medications are not working, a Mirena is not working, you have already exhausted those options, then you can recommend a hysterectomy to her. So, as if the only thing the uterus does is, like, produce children. So that was the thought. And I hope it has changed now. I don't know. So my point in talking about hysterectomy is, don't decide about a hysterectomy very easily. Yes, of course, there is a role of hysterectomy in non-cancerous conditions, but not like a willy-nilly thing. Oh, okay, I just tried the medicines for 1 month, they didn't work, so I'm going to go back and have a hysterectomy. It's gone once and for all, and I'll be fine. So no, you wouldn't be. And I am someone who had a hysterectomy at the age of 40, and I have no one to blame, only myself. I had a huge fibroid, and I thought, okay, the usual, I didn't want any more children. And I was sick and tired. That fibroid was like, in my life for many years. So in fact, when it was diagnosed, Lily, I was about 20 years old. And I remember my, head of the department of OBGY, she was my doctor, and she said, oh, are you planning to get married soon? I said, oh, no, I didn't have any plans of getting married at 20. Anyway, so my fibroid behaved itself well to the point that I could finish my MD and everything, and during MD I could get married. But bottom line is, I was dealing with that fibroid. It was a big one. So by the time I actually had the surgery, it was about the size of a 6 months pregnancy. Now, I have no one to blame but myself to have a hysterectomy. In fact, I had one or two colleagues telling me, Shabnam, are you sure you shouldn't just have a myomectomy, which is like removal of just the fibroid and not the whole uterus? I said, no, I'm sick and tired of having excessive bleeding, and sometimes it's very painful. It's like gone and done. Now, fortunately, and this is where nothing but luck, I would say, Lily, that around that time, you were the person who introduced me to bioidentical hormones. So the good thing was that I started hormone therapy soon after hysterectomy. Now, that is not the story with many women in India, I know. I don't remember ever recommending hormone therapy for, even women who had had an obstetric hysterectomy. So obstetric hysterectomy meaning because of some pregnancy complication. And obstetric hysterectomy is an emergency procedure. Like the woman is bleeding and bleeding away, and there is no other way to save her life other than doing a hysterectomy. So that is an obstetric hysterectomy. I don't ever remember, Lily, recommending hormone therapy to any of those women. Did you do any of
Oh,
that
poor
before?
thing, pat her head and it's done.
Yeah. And we just sort of, they came back feeling poorly. Sometimes I remember sending them off to the psychiatrist, because back then I didn't know how much of an impact, hormones like estrogen, progesterone, and all these had on brain function. So all these hormones, when we talk about menopause and how hormone levels impact your health. So what happens after menopause when these hormone levels are drastically reduced? So these hormones don't just work on the uterus. They work on your brain, they work on your heart, they work on your bones. They work actually, estrogen has about 400 different functions in the body. But Dr. Lily and I know many of you here you've heard me and Dr. Natasha Iyer talking about hormones as well. One of our favorite hormones is actually progesterone. And for some reason, estrogen gets so much more of, I don't know, what do you call it, more of importance. Whereas progesterone is extremely important. So another thing which, recently I was talking to a lady who wants to bring about awareness about the perimenopausal transition. So perimenopausal transition is 8 to 10 years before your final menstrual period. So final menstrual period is, uh, and menopause, unfortunately, the diagnosis of menopause is kind of retrograde in the sense that it is 12 months from your last cycle. So if you are 6 months into menopause, you technically won't be called in menopause. But the perimenopausal period is very important, because a lot of women go through numerous challenges at that time: mood disorders, sleep problems. Some even may have, hot flashes, though they are not as common. Then they have joint pains, muscle aches. And very often, and I'm sorry, my apologies to my patients if I have done that, and I could have done that back then. Many of these women are sent away saying, oh, it's all in your head, or they're given an antidepressant medication. No, these are problems because of the hormonal irregularities at that time. Some women go through, irregular cycles at that time. So what happens is we are finding out more and more about the hormonal milieu at that time. So some women have very high estrogen at that time and very low progesterone. So that again, unless you check, you won't know. And the treatment for that period is quite different. Hormone therapy at that time is quite different. You need more of progesterone and maybe no estrogen at all. Then there is, of course, DHEA and testosterone. I don't want to get into hormone therapy today, because for a lot of people from India, it's like hormone therapy is not commonly available. I have changed my approach now. I decided I'm going to start with what is available in India, rather than wait for for a bioidentical compounding pharmacy to be available there. So whereas those of you who are here, I know a lot of you here in Canada as well, you know what to do. So Dr. Iyer, my associate here, she is known for hormone therapy. So, Lily, it's so unfortunate that you can't hear me. So, one thing
So
is,
now I think it's a little better.
it's a little better. Okay, great. First and foremost, we were talking about not having a hysterectomy willy nilly. Like, don't take that decision lightly. You need to give it, a good thought and have a discussion with your doctor to find out if there are other options. And of course, we need better treatment. Like some places, it's, for example, having a myomectomy, even if you have, so myomectomy is removal of the fibroids only and not the uterus. Even if you have multiple fibroids, you still can have a laparoscopic surgery. And unfortunately, Dr. Lily is a laparoscopic surgeon specialist. So Lily, if you can hear, will you add a few things? Because sometimes what happens is many patients are, because they've been given the wrong impression that if they have had previous surgery, if they have too many fibroids, they cannot go through a laparoscopic myomectomy. That is not true. It depends on the skill of the surgeon. So Lily, will you add a little bit about that from your perspective as an endoscopic surgeon?
Yeah, of course. There are instances when we have removed fibroids which are of a 6-month pregnancy size. So that would be like a 6 inches,
Big.
this large a fibroid. Or there are multiple fibroids. Actually, we were taught to believe that if there are multiple fibroids, then you're going to leave the uterus looking like a sieve. So why do that? Why not just do a hysterectomy? But now we know that conservation is a much better choice. We conserve the uterus, we conserve the ovaries, we conserve any organ that we can really.
Yeah. So first is don't have a hysterectomy easily. Go through that decision very carefully with your doctor. Look for options. Number two is it depends, like I said, whether to have a myomectomy or a hysterectomy. A lot depends on the surgeon's skill. So that is important. Now, this information is relevant to people in India, not relevant to people in Canada, because they cannot choose their surgeon, and the surgeon would usually have a discussion with the patient. So that is not the thing. Next thing is, that if you've had a hysterectomy early before the age of 45. So in India, the average age of menopause is actually, Lily, it's lower than in the Western countries. So it's about 46, 47. So if you have had a hysterectomy already, maybe you need to talk to your doctor about hormone therapy. And again, I'm not going into that conversation today. And because the other thing is, again, we were not taught about hormone therapy back then. And even today, I'm actually surprised to know how, like, the information has not seeped in. So just briefly, I'll talk about so estrogen applied to the skin. So transdermal estrogen does not raise your risk for heart disease, stroke, none of that. Because we've had actually even here patients being told by their cardiologist, oh, the hormone therapy is going to kill you. Well, no, it is much more nuanced than that. And the progesterone component is the one that is recommended now, is what is called oral micronized progesterone, so OMP. That is very different from the progestogen that was used before. So this is before. Again, in the interest of time, I'm not going into, because we have talked about hormones in other webinars. So the hormone therapy recommended now is 17 beta estradiol, that is estrogen. And I'm mentioning these long names because I know there are a lot of doctors in the audience as well. So 17 beta estradiol on the skin as a cream. That does not raise inflammation, that does not raise your risk for heart disease, but it does give you the other protections. And the progesterone component is the oral micronized progesterone, not the medroxyprogesterone acetate that was used before. So don't bother with the long names. It's mostly medical related, but then you can just Google them as well. And what is different about the hormone therapy that we recommend, which is a major difference between the traditionally recommended hormone therapy, is in traditional medicine, if you have had a hysterectomy, don't have a uterus, you don't need progesterone, because apparently the only function of progesterone is to protect the uterus lining. That is not true. Progesterone has a lot of functions in the brain, and being progesterone deficient may actually rob you of sleep. So like I said, progesterone doesn't get the importance it deserves, but progesterone for me is life-saving. So yes, I am on estrogen and progesterone even after having a hysterectomy. And one of the very common symptoms that women in the perimenopause and menopause as well describe is weepiness, like crying at every silly thing. And what happens very often is it becomes like a joke in the family. Oh, mummy cries at every stupid Hindi movie or a television serial. But there is a biological reason for that. So my point is, you shouldn't feel bad about it. You shouldn't, because you don't know what is causing that. And I'm sure many women have gone through this horrible experience of, what is wrong with me? Like, why am I crying at this? Without knowing that it is probably the hormonal imbalance causing the problem. And this is so sad across all conditions, where women are just told, oh, it's just age, you're just getting older, just get used to it. you know and sort of like poo-pooed away, and whereas we did have biological explanations for that. So I'm just looking at the time. So one is hysterectomy, what we talked about. The next I have major, concerns about is the treatment of PCOS. So Lily, I mean, earlier we used to treat, and that is the standard of care. So PCOS is polycystic ovarian syndrome, where a lot of women in India, it's actually young girls, so adolescents and girls in their 20s and 30s, they have obesity is very common, excessive hair growth, and irregular cycles. Many of them miss their cycle, they don't get their cycles regularly. And this is actually the underlying problem is something called insulin resistance. So basically, the hormone insulin doesn't function optimally the way it should, and blood sugars go up. So they are prone to diabetes, heart disease, and this risk actually stays throughout life. And of course, some of them have problems getting pregnant as well. So fertility issues are also there. So PCOS is extremely common in India today. Now, my concern, Lily, is because I've been getting a lot of young women with PCOS who have hypertension. We didn't see a lot of hypertension in young women before. I'm talking about 10, 15 years before. Now it has become commoner. And again, we don't know the exact reasons. And it's not just women, actually, even amongst young men, in hypertension has become more common. Unfortunately, they don't know they have high blood pressure, because obviously no 25-year-old decides that I'm going to get my blood pressure checked today. So going back to the treatment of PCOS, so one of the treatment of PCOS is giving them synthetic hormones combinations. Usually it's similar to a birth control pill, but the combination of estrogen and progesterone actually is different. Unfortunately, these birth control pills, or the ones that are used for PCOS, they will regularize cycles, but they are not indicated for women who have hypertension. So this is something that bothers me, because the unfortunate thing is actually probably a lot of people are not aware that other than treating PCOS women with birth control pills, it is possible to treat them with only oral micronized progesterone. So that is the way, that is what I do. But again, some of my patients are not happy, because it takes a little bit more time to regularize the cycles with the oral micronized progesterone, and you need a higher dose. And a lot of that work has come from an endocrinologist in Canada, Dr. Geraldine Pryor. So she's been working relentlessly, and so her website has a lot of this information available. She's trying a lot to bring about awareness about the perimenopause and how there is a huge difference in the estrogen and progesterone at that time. And the other unfortunate thing is these young girls who are on the birth control pills. Now, some of these young girls are on birth control pills because they need contraception. They have also had bone loss. So Dr. Pryor came up with a paper, I think fairly recently, where, and you don't want young girls losing bone. I mean, nobody wants losing bone at any time. But so this is my, I just wanted to highlight these things. Number one, PCOS and hypertension are also present together. So this is not, these birth control pills for regularization of cycles. It's good for regularization of cycles, but it will get in the way of your hypertension treatment. So Lily, we're almost coming to an end, and we'll open for questions in a little while, but just in summary, the few things you can do for yourself. Number one is get your blood pressure checked. Get one of those instruments. They don't cost a lot. You find them on Amazon. Go for a clinically validated one. And on my in my article on hypertension, I have a link to the website which shows which are the validated ones. Get that. Check your blood pressure for at least morning and evening for 10 days, 14 days. If you get 10 readings, that is more than what you would usually do, and that will give you an idea of where your blood pressure, how your blood pressure is trending. And the number that you should aim for is 120 by 80 millimeters of mercury. So the numbers have changed. And if you have hypertension and your blood pressure has not reached that level today, it doesn't mean that you need one more medication. There are other things, like weight loss is one of the big ones to reduce your risk for hypertension or reduce actual blood pressure. Deep sleep, Deep sleep is one of the best antihypertensives. So these are two big ones. Then of course there is movement. If you uh, sitting disease is something I we have talked about a lot, and because we are running out of time, so avoid continuous sitting. What is your daily step count? If you don't know your daily step count, maybe it's, again, I'm someone who wears a wearable all the time, and I highly recommend to any of you, don't have to necessarily get a fancy smart watch. There are cheaper versions available. And I have another pet peeve, Lily, that they don't make wearables for women. They're like big and ugly. Anyway, that's a different story. So get a wearable because it'll help you track. Because the other thing is, when you improve something, you won't even know unless you measure. So I think it was Peter Drucker who's supposed to have said that what you don't measure cannot be improved. So if you are, let us say today your daily step count is around 3,000 to 4,000, that is sedentary. You need to raise it at least to, okay, so 10,000 steps a day is what we assume our hunter gatherer ancestors did, but we don't know for sure. However, increasing your daily step count by as little as 2,000 steps. 2,000 steps is a walk around your building, your society. A 20 minutes walk can give you 2,000 extra steps. That the factor that you've increased your daily step count by 2,000 steps can have a huge impact. It seems like a very small thing, it's like, oh, what, just a 20 minutes walk. Yes, that can also have an impact. Now, if you are already meeting your, the daily step count, you are already very active. The other thing you need to look at is, are you sitting continuously? Because I know a lot of people, what they do is they walk the dog in the morning, and then they have, let us say they are going out for something else later on in the day. But in between, because of the nature of our work, they sit continuously at their office table for 5 to 6 hours. That will actually counter all the benefits of the exercise in the morning, going to the gym in the morning. So if you are already meeting your daily step count, what I would suggest is, are you active every hour? Are you interrupting your continuous sitting? So what are the things you can do? One is, like, I have started using a standing desk. So I have a little small little table which can be raised up and down and all that. It's nothing fancy, nothing very expensive. If you can go for a treadmill desk or something, fantastic. But my point is, otherwise just put your laptop on a bunch of on a whole lot of books or something. Find a way. That's my point on how you can. And again, the other important thing is, you cannot stand continuously. So you should definitely interrupt your continuous sitting, but don't stand all the time. That is also important. So a desk that can either be raised or brought down, or figure out a way. And the other thing is, if most of your sitting is watching television, that is again something you can, and I'm not saying don't watch television. What I'm saying is, maybe at that time don't sit. You can start doing simple exercises, or maybe consider sitting on one of those stability balls. Like, then you're not really sitting on a chair. And so what happens is, your muscle mass is reduced if you sit continuously, and muscle is very metabolically active for your long-term health. So having good muscles is important for your blood glucose. It's important for your lowering your inflammation. And sitting actually gets in the way of your metabolism completely. So that is one thing. So one, I talked about hysterectomy. Next is hypertension, know your blood pressure. Third thing, I talked about avoiding sitting disease. And fourth thing, when Dr. Lily and I are talking, we cannot not talk about food. So in the interest of time, I'm just going to talk about one thing you can do today, if you have not done it already, is get rid of all the vegetable oils from your kitchen. Vegetable oils are the highly processed seed oils. Some of them, unfortunately, have the heart healthy signs as well. So get rid of the vegetable oils. And again, the vegetable oil discussion, Lily, actually would probably take 1 hour, because I realized last time I went to India that it's very difficult to find out which are not industrially processed. So I would talk to patients about, what was the traditional oil your ancestors used, maybe your grandparents used. And some of them would say mustard oil. So even my ancestors used mustard oil. But I think one big problem is the mustard oil that is probably here, we would call it the cold pressed mustard oil versus the industrially processed mustard oil is definitely not the same. But again, we don't have easy solutions. Ghee and butter are probably better if you can tolerate that, if you don't have intolerance to those things. But the seed oils, all those ones with the, the so-called heart healthy signs, please get rid of them in your kitchen. More importantly, another big thing is, when you eat outside, most people apparently it's true even in Canada where they have such high, stringent regulations about food and all that, that the what I call the triple fried oil, so they use the same oil to fry repeatedly, that has like a huge negative impact because it creates trans fats and all those horrible things. So the same food, if you are cooking at home, you're controlling the oil. And I know most of you in India, usually many of you don't do your own cooking. You have someone helping you with it. So you can tell the person who cooks for you that same thing, whether you want to have, let us say what, fritters, pakoras or vada. I know in Mumbai, vada pav. Of course, it's potatoes and that's carbs, but still, if you are frying that at home in oil that you know what it is, and it's not a triple fried oil, then that is way better than what you would buy from your local little shop. So this is just my recommendation about food. Yes, we can go do a much deeper dive onto carbohydrates and all that. So Lily, I'd just like you to add a few, chime in a few things that you would recommend for our audience, and then we'll open it up for
Like to
questions.
tell us about the role of insulin resistance, Dr. Sharma?
Insulin resistance. Okay. Lily, we'll run out of time. So, insulin resistance, like I said, basically is the problem where the hormone insulin doesn't function well in your body. So, how will you know if you have insulin resistance? Number one, if you have belly fat. And this is again really so shocking. I'll find, sometimes talk to young women in India and they say, I don't have a weight problem. And I can see that they have belly fat, like the belly is like a 6 months pregnancy, but they go by the old ancient way of BMI. So BMI, in terms of BMI, they are okay, but that's not the number we are looking at. And again, Asian BMI is different for what it is for the Western population. So belly fat. And the other important easy way to know is your belly should be half of your height. So if you are 150 centimeters tall, then ideally your belly should be 75 centimeters. So that's a very rough measure, but fairly easy to know. Then next is if you have PCOS, that is insulin resistance. That's like, as someone describes it, as diabetes of the ovaries. Then the third thing is if you have had pregnancy diabetes, that is another one. Then if you have had an ultrasound and you've been told you have a fatty liver, that is also insulin resistance. If you have had some blood tests and your fasting blood glucose is, again, you are not in the diabetes range, but it is higher than 85 or 90. I think the labs say 100, but 100 is too much for us. So 85, 90. So that's 4.9 Canadian units. That is not good. Then the other thing is hypertension itself is sometimes, of course, related to insulin resistance. Then, so if you've had blood tests, having high triglycerides. So when you talk about, lipids, your cholesterol is high. No, cholesterol is not the major culprit. For women, having higher triglycerides is a much bigger risk factor than anything else. And high triglycerides cannot be taken care of by a statin medication, by a cholesterol lowering medication. That one of the things you can do is reduce your carbohydrate intake, and the other one is omega-3 fatty acids. That's for another conversation, run out of time. Another few more blood tests are SGOT, SGPT, so ALT, AST, depending on which country you're in. If those are again, usually they're called liver function tests, but they actually talk about your metabolism as well. If they don't see in abnormalities, they go into the 3-digit levels, not that level. Let us say the range is, I think, up to 35 and 40. Having more than 20, 25 of both those numbers is again another indication for insulin resistance. Another big one is uric acid. So blood uric acid levels, it's not just gout. Having higher uric acid levels is again another risk factor. So that is also insulin resistance. And for high uric acid, what is the just one small recommendation is get rid of all the sugar. So the fructose content of food is directly related to the uric acid. And more importantly, it is not the protein containing food. If you have gout, again, that's for a different conversation because we're running out of time. So Lily, unless you have any more questions, I'm going to open it up for questions. And how you can ask a question is because all of you are in listen only mode. So you can go to the bottom where it shows chat, go to the chat option and you can type your questions and Dr. Lily and I will respond to them as far as possible. Lily, anything you want to add while we wait for questions?
You believe that maybe an 80-year-old or a 90-year-old, somebody who's really elderly, can be perfectly healthy and without any risk of a cardiovascular disease or stroke?
Yes, I have met them. Yes, it is absolutely possible. And because, it's, again, it depends on how their lives are at present. And there are a lot of things that are going to come up now. So recently I was going through a book by Dr. Nir Barzilai, who's done a lot of research on longevity. So he has done a deep dive. So he looked at the centenarians. These are people who are like 100 years old. And of course, genes have a huge impact, but lifestyle does as well. But what is interesting is he found that many of these centenarians are not necessarily, people who don't smoke. There was a centenarian, she used to smoke all the time. So bottom line, so someone asked her, didn't anyone ever tell you not to stop smoking? She said, all the four doctors who told me to stop smoking are dead. So my point is not that you should start smoking. My point is there is a lot we don't know. And but the interesting thing is it is possible. So it's important for us to find out what did they do and how can I apply that to myself. That is most important. So Lily, that is my short version.
What is the role do you think of practices like meditation?
Meditation, okay. I am biased because I've been meditating for like I think longer than 10 years, and I write meditation as a prescription. So meditation is again, there is no religious connotation to meditation. If you don't like religion, there's nothing to do with religion. So mindfulness based stress reduction, what it does, it's not just about stress actually. Yes, it does help you. See, your stress will not go away if you meditate, but you will handle your stress much better. So if you have never meditated before, and we have lots of studies now where it shows how meditation changes your gene expression. So it's not just feeling good and being in a calm and this thing state. Even there are so many medical studies now, clinical studies evaluating the benefits of meditation in terms of managing even conditions like cancers. So it's not that the cancer goes away with meditation. No, you are able to deal with it much better. Inflammation reduces, your blood sugar goes down, blood pressure is maintained better. So bottom line is those who are meditating, yes, wonderful, go ahead. Maybe you might consider increasing your meditation time. If you have never meditated before, I would suggest start off with some, simple phone app, a free app, go through a guided meditation and see how you do. Don't be judgmental. Don't keep telling yourself, "Oh, I can't stop my brain from thinking." That's like asking the heart to stop beating. So it is a process. Start with 5 minutes a day, but probably to get better health benefits, you will need about 30 to 45 minutes. Different things for different people. We still don't know the exact numbers, whether 15 minutes in the morning versus and 15 minutes in the evening is better than 30 minutes together. I would think doing 30 minutes together has, again, I find that beneficial, but it's different things for different people. And some people, again, one thing I wanted to talk about sleep. Some people say, oh, you need to meditate before sleep. No, it doesn't always work that way for everyone. See, meditating before sleep, if you have chronic insomnia, may not help you because meditation gives you relaxation, not sleep. And for me, during meditation, my mind actually, I get a lot of ideas during meditation. So I don't meditate just at bedtime, because that gets my, sometimes I have to sit and write down the ideas that come up. So, do we have any questions?
I have one more question.
So please feel free to type your questions in the chat box. And we are 2 minutes, 20 seconds over our time limit. I don't want to keep you all waiting. And Lily, do you see any questions? I don't, not yet. Okay, so what will happen from
Have
now?
any feedback? Do any of
No,
us
we
would
don't
like
have any
to?
questions. You can read the chat.
And
We don't have any
anybody would like
questions
to
yet.
give us some feedback? What did you like?
So,
What would you
yes.
like us to do in the next such thing, such seminars? Anything that you would like us to address?
And most importantly, this is what I usually say at the beginning. And today, with all the audio challenges, I got sidetracked. So it's wonderful to sit and get a lot of information. But the most important thing is, what are you going to do differently moving from today? Like, with the information that Dr. Lily and I have shared, have you made any decision that you're going to do something different? Like, you're going to start measuring your blood pressure, or you're going to start increasing your daily step count, or you're going to throw away the vegetable oils. Those are going to be much more important than both of us talking about all the different things. So that is what is applicable to you, and what can you do starting tomorrow. Or for those of you in Canada, it's a Saturday morning. What can you do different starting today?
How
So
about
while we,
having a positive mindset?
oh,
Like reference
absolutely.
the particular study that they did where they took patients, where they took people into an area where they made them think that they were 20 years younger, and it came out feeling 20 years younger. So if
Mm-hmm.
we could think that way, maybe we could be that way.
Mm-hmm. Thank you. Yes. Thank you, Kathy. Thank you for, she says, I really appreciate the information. Thank you very much. And thank you for, and okay, and about what we can do to help, and what indicators to look at to recognize the problems. Kathy, thank you very much for waking up early in the morning on a Saturday and joining us here. Uh, so I'm going to send the link to that website that I said, which has a list of all the risk factors. And you will receive a recording of this webinar as well. And I will add a link to that too. And so what will happen once you go through that question, that the checklist? So you will know which are the ones you're ticking. And after that, you'll probably have to wait for about 24, 48 hours before which you receive the response, because this is again some tech glitch at the back end, which I have to deal with. So I have to manually send the reports to send your score to you. And the other thing is, if you want to join. So Lily, do you have like an email you'd want to share in case anyone wants to reach out to you? Where would they find you? You can type it in the chat box and address it to everyone. Okay. I think Dr. Lily can't hear. I will. Oh, okay. Oh, so Dr. Lily has posted the link to her website. So if any of you want to get in touch with her, you can do that through that. And see you all next time. And I want to know, what is the difference that, whatever Dr. Lily and I talked about, did it make a difference to what you are going to do tomorrow or today? And if you have any questions, feel free to email my clinic, info at the rate drkarmd.com. And happy hearts and brains.
Thank
Bye
you so
now.
much, Dr. Shabda. It was such an
Thank you,
enlightening
Lily.
talk.
It's a pleasure
And
to be with
I
you.
think it really made a difference. And I'm sure everybody loved what you said. And I'm
Thank you.
very much hoping that everybody will definitely take some steps to make some changes.
Yes, thank you.